এই ভিডিওটা হলো আমার এবং আপনার মধ্যে একটা ডিসকাশন। আমি জাস্ট এআর নিয়ে কয়েকটা খুবই হাই ইয়েল ডিসকাশন করবো আজকে। এআর মানে হলো অ্যাওর্টিক রিগার্জিটেশন। সো অ্যাওর্টিক রিগার্জিটেশন নিয়ে আমি আপনাকে কিছু কোয়েশ্চেন করব। আপনি চাইলে ভিডিওটা পজ করে আপনি কোয়েশ্চেনের আনসার চিন্তা করতে পারেন বা আনসার দেওয়ার চেষ্টা করতে পারেন। দেন ইউ হিয়ার মাই আনসার. So I have my notes here, and now let's start discussion about aortic regurgitation, or simply AR. Okay. So first thing first, দুইটা main cause. What are the two main causes of aortic regurg? The two main causes are the aortic valve pathology and root pathology. If there is an issue with the valve, causes regurg. If there is dilatation of the aorta or ascending aorta, that also causes regurgitation due to non-coaptation. Those are the two main causes of aortic regurg. Okay. Next question is, what is the classic congenital cause of aortic regurgitation? The classic congenital cause is a bicuspid aortic valve, and usually the right and the left coronary cusp fuse in more than 80% of the cases. Now, next question will be, what are the causes of dilatation of the aortic root? So the root dilatation classically occurs with the congenital disease or the connective tissue diseases such as Marfan syndrome, Ehlers-Danlos syndrome. But there are some acquired causes as well. For example, it can be due to simple hypertension. It can be idiopathic, I mean, there is no specific cause. It can be due to autoimmune diseases such as SLE, ankylosing spondylitis. And previously, it was due to syphilis, syphilitic aortitis. Even vasculitis such as Takashi arteritis can also lead to dilatation of the aorta. And in acute cases, aortic dissection and aortic aneurysm, they are also associated with aortic regurgitation. Next, let's go into the discussion, the question, which type of air is more dangerous? Is it chronic air or acute air? The answer is, the acute air is always very dangerous. Why? Because whenever you have a chronic air, the LV actually remodels itself or gets adapted to the volume overload. But in case of acute air, there is no such time for getting adapted. And that's why patient developed acute LV failure and pulmonary edema. So acute air is more dangerous, more deadly, and requires aggressive treatment and even early surgical treatment. Otherwise, the patient has a high risk of dying or mortality. Another important question is, what happens to the coronary blood flow during air? Because we know in air, the diastolic blood pressure is often very low. But the coronary perfusion, the blood flow through the coronary arteries happens throughout the diastole. So how, if the diastolic pressure is low, now how the heart gets the blood? Because the pressure gradient is so low. The answer to that is, there is compensatory dilatation of the coronary arteries that maintains the perfusion. So that is dilatation of the coronaries. Now let's talk about the high yield peripheral signs of aortic regurgitation. So what are the important signs that you find peripherally that diagnose or that indicates aortic regurg? So the first sign, most important sign, is you find in the hand, which is the collapsing pulse or the water hammer pulse. That's what you find when you take the radial pulse of the patient and lift that hand and feel that water hammer. the pulse will collapse and then will come back and collapse, and it will hit you like a water hammer. So that is the water hammer pulse. Then if you inspect the patient's neck, if there is dancing carotids, that is called the Corrigan's pulse, or simply dancing carotids. Then you can find some signs in the fingers. So in the fingers, if there is pulsation of the finger, that is called a quincke pulse. Pulsation in the finger, the nail bed pulsation is known as a quincke's sign. Then if you auscultate the femoral artery, you can find a double sound. That is called a trop sign. And that is often referred to as pistol shot. They can be used as similar sign. So I would say they're almost similar. So no need to differentiate between those two. So trop sign is when you find a double sound over the femoral artery, but without compressing the artery. But if you find a diastolic bruit or a systolic bruit, when you compress the artery, that is called a Durogius sign. That's where the confusion arises. Trop sign is the sound that you find without compression, but the Durogius sign is a sign when you compress the femoral and you find a murmur-like sound or a bruit with compression of the artery. So with compression, Durogius; without compression, the trop sign. So in case of Durogius, if you compress the femoral artery distally, then you find a diastolic bruit. But if you compress the artery proximally, you find a systolic bruit or systolic component. That's it. Next is if the patient's head moves like this or there is head nodding, that is called a de Mouset sign. All the signs happen because of the wide pulse pressure. Because of wide pulse pressure, the head just moves around because the head is sometimes getting so much blood and then the blood is gone to the heart back to the heart. So the head nods by the very high or very large change in the volume of the blood in the arteries. Then the head nods. So that is the de Mouset sign. And if you just see the uvula, if the uvula pulsates, that is called Muller sign. Muller sign. Then if you look at the eyes, if the patient's pupils constricts and dilates, that is called Landolfi sign. Landolfi sign, or alternating dilatation and constriction of the pupil. Then there are many other signs. For example, in the abdomen, if there is pulsated liver, that is called a Rosenbach sign. If there is pulsated spleen, that is called Gerhardt sign. Then in the leg, there are few more signs. If the leg blood pressure is at least 20 millimeter mercury more than the arm blood pressure, obviously that's a systolic pressure. If the systolic pressure in the lower limb is more than 20 compared to the upper limb blood pressure, that is called a Hale sign. That was a classic sign. Even there was a classification system based on the Hale sign, and the minimum cutoff was an increase in 20 millimeters of mercury. And there is one other classic sign that was described by Abraham Lincoln, the president of the US. That is when you cross the legs, put one leg over another leg. Due to the rapid change in volume, there may be exaggerated movement of the ankle. So cross leg, exaggerated ankle movement, that was seen by himself in him. Abraham Lincoln was an aortic regurgitation patient. So that was a sign that he noticed, and he actually notified this, and now this is known as the Lincoln sign. This is the movement of the ankle, alternating movement or frequent movement of the ankle after you cross the legs. That is Lincoln sign. Now those are the signs. Now let's talk a bit, with very high yield questions. So let's start with some questions asked in the exam, high yield questions. Now, what are the clinical indicators of severity of aortic regurg? How do you know clinically that this patient has a severe AR? So first start with the pulse. If the pulse is high volume and collapsing, severe AR. Then the blood pressure. If systolic blood pressure is high, diastolic blood pressure is very low, that is white pulse pressure. And here, if the white pulse pressure, the pulse pressure is at least more than 50% of the systolic, now that is a very important indicator of severe AR. So very wide pulse pressure, at least more than 50% of the systolic, and that is a severe AR. Or if the diastolic is less than 40 millimeter, another sign of severe AR. Another thing is the peripheral sign. All the peripheral signs usually indicate at least moderate and oftentimes indicates severe AR. The Hill sign, if the limb blood pressure, lower limb blood pressure is more than 40 millimeter compared to the upper limb, that is severe AR. Now, another high yield question is how to measure blood pressure in patients with severe AR. Is there any difference between a normal patient and an AR patient? The answer is yes, there is difference. And the difference is whenever we are measuring the diastolic in a normal patient, the cutoff or the point at which we call it diastolic is the fifth Kortkov sound. But in case of AR, the fourth Kortkov sound is taken as the diastolic blood pressure, not the fifth. That's the difference. Another question is, how can you define the severity of AR based on precordial finding? So we have already mentioned in a previous question that the severity of the AR is clinically seen by the pulse and the pressure and the peripheral signs. Now, what are the signs of severity that you can find in the chest? So the findings that you can find in the chest is first, apex. If the apex beat is forceful, ill-sustained and shifted, so shifting downwards and laterally, that indicates LV dilatation. That indicates a severe AR. What else? In auscultation, if you find the Austin Flint murmur, that is a mid-diastolic murmur due to fluttering of the anterior mitral leaflet, that is also an indicator of severe AR. And if there is high volume, oftentimes there is a volume related or a flow murmur in the aortic area, that also suggests that the patient is having a severe AR. Next important question is, can you use antihypertensive in a patient with aortic regurg? Now that is tricky because we know that the diastolic blood pressure is already very low in patients with AR. So if you use antihypertensives, the pressure may fall further. But the point is, the diastolic blood pressure is not the most important thing here. The most important thing is to control the systolic. Even if the diastolic falls, it does not matter that much. But you have to control the systolic blood pressure because that is related with morbidity and mortality. And higher systolic blood pressure will also lead to load to the heart. It will cause a pressure overload in the heart along with the volume overload. So you have to control the systolic blood pressure and you can use antihypertensives except the beta blockers. Now the next question is related to this one. What's the role of beta blocker in AR? Can you use it or should you avoid it? The simple answer is, in most cases of AR, you should avoid the beta blockers. Why? Because beta blockers reduces the heart rate. A slower heart rate means a wider diastolic blood pressure, wider time of the diastole. So if the time of the diastole is long, then the time for regurgitation is also long. So the more blood will come back to the heart. So the regurgitant volume or regurgitation volume will be high. That is bad. So you don't want to lower the heart rate because that will increase the regurgitation. But some cases you must use beta blockers. For example, if you have aortic diseases such as Marfan syndrome, or if your patient has already developed heart failure, then you have to use the beta blocker as an important medication for controlling the heart failure. Next important question is, when do you send the patient of air to surgeon, or when the patient requires surgery? The simplest answer is, if the patient has symptoms, all right, send the patient to surgery. But what about the asymptomatic patients? Will you send them to surgery, and when is that? The simple answer is, you should send the patient to surgery if the ejection fraction is 50% and falling.